Thank you, our eminent speakers, for the very useful presentations. I don't know if I can receive questions from the audience, available audience, if there are any. I have some questions from the virtual audience anyway. So, Dr. Sara, thank you for your direct focus on SARS and diabetes. I have a question. Do the different variants of SARS affect the prognosis or affect the progression to diabetes? Did you come across anything like that?
So that's an excellent question, and the short answer is no, I'm not aware of that. I think what has changed is with vaccination, the disease itself has changed hugely. Certainly with the older classical variants, the alpha and the beta, there was quite a lot of diabetes being diagnosed. With a more recent wave of Omicron, we have seen large numbers of very mild disease. There's been few patients with severe disease, and actually COVID and diabetes are related in those. As Professor Pozzilli has just said, those who end up in ITU, who have a severe cytokine storm, or even those who end up in hospital. The numbers aren't out yet. The wave has just almost finished. So wait and see, I think, is the answer. I'd be grateful if my Professor Bain or Professor Pozzilli have anything to add, if they could jump in, please.
Thank you very much, Prof. Bain. Very interesting topic. Can we diagnose the subtypes phenotypically without going to the biological markers and the genetic markers? Is it possible at some stage in our clinic that we can formulate a phenotype, a type where we can diagnose the patient accordingly?
So I think it's difficult depending on which type of diabetes you're looking at. I think we're all familiar with the common types of type 1 and type 2 diabetes, but it's worth pointing out that the use of GAD antibodies to identify people with LADA actually was substantially made using the UK PDS study, the United Kingdom Prospective Diabetes Study. And that was a collection of newly diagnosed type 2 diabetes patients. And so even in the setting of a study, people were getting the diagnosis wrong back in the 1980s when people were being recruited. For some of the monogenic forms of diabetes, the fact that you've got a very powerful family history and where the phenotype is identical in different generations is very helpful. But you still have the situation where novel mutations, being that a family history may not be present. And if you look at mitochondrial diabetes, for example, the actual phenotype is highly variable, even in the same pedigree. So I think the answer is, in some cases, yes, but in an awful lot of cases, the answer is no.
Thank you very much.
If I may add to what Steve said, that we're talking about Middle East now, so population in the Middle East. Now, the number of patients with LADA, we did a study with Nadir Lessan at the Abu Dhabi Center for Diabetes, and other studies done in other parts of the Middle East. LADA is actually double the figures that we observe in Europe, suggesting that if overall, we're talking about 10% of all patients with apparent type 2 diabetes have LADA. Indeed, in the Middle East could be even 20% in some regions. So I think that measuring GAD antibodies, that probably is the most reliable antibody and to measure, you can immediately figure out that some autoimmunity is present, and therefore your approach can change, because you can measure C-peptide, you can find out how much insulin this patient have. And then recently we published the guideline for LADA. It was published in Diabetes in October last year, a consensus paper with David Leslie, myself, Raffaella Buzzetti, Tina Tuomi, and Riccardo Buchor-Porel. And in this consensus paper, we actually define treatment based on C-peptide levels. I think this is definitely very helpful and simple to apply, because you just have C-peptide below 0.2, definitely insulin has to be given. But if you are in a gray area between 0.2 and 0.6, 0.7 in that nanomolar liter, in that gray area, you have a number of molecules that can be tested. Probably the best of them all is the DPP-4, because there's been some evidence that the DPP-4 delay the onset of insulin requirement. If you have a C-peptide greater than 0.7, then apply the type 2 diabetes guideline that currently we apply. So this is a typical example of how a laboratory test may help to define which are the drugs to be used in patients with LADA. First, you recognize the form of diabetes, and then you apply the best potential treatment for these patients.
Just to follow on from what Paolo's saying here, that the GAD antibody itself is not sufficient to tell you what the patients will need in terms of treatment, is it? Because I recall we were part of the Action LADA study 15 years ago.
We did.
Yeah. And Prof.
We had a patient with extremely high anti-GAD antibodies, and yet at the end of the study was still not on insulin because tiny doses of insulin rendered her hypoglycemic. Right. So you need something in addition to the GAD antibody level, as you say, C-peptide.
C-peptide. C-peptide is definitely.
And the antibodies in our generation is not as confirmative as in your group, in your population. In our population, in the Caucasians, it's more of affirmative of the, maybe more affirmative the diagnosis than in our population. Does the Abu Dhabi study say that?
So thank you very much, Professor Pizzilli. I work in the same department as Dr. Nader Lissan, and that was a lovely paper, the LADA paper. I think actually antibodies do confer a risk of both type 1 and LADA. I don't think that is any different in the Middle East than it is in the UK or anywhere else. Going back to your initial question of practical, simple things that we can do, obviously C-peptide and antibodies are helpful. In patients whom we think might have MODY, actually an oral glucose tolerance test is also very useful, particularly for those with a glucokinase mutation. They have a very small increment between their fasting and their 2-hour. And that is in places where money is tight, maybe that is a helpful test to do before sending them for genetic testing. As a comparator, people with HNF1 alpha or HNF4 alpha do have quite a large increment, pretty like type 2 diabetes.
I'm interested to know Paolo and Sarah's comments about urinary C-peptide or C-peptide in general, because I think it's important to note that there needs to be a period of duration of diabetes before it becomes really useful. And I know we're involved in a type 1 diabetes immunotherapy study at the moment, and so testing people very early in the course of their type 1 diabetes. A significant proportion of them have got a C-peptide above 0.2 at the time around diagnosis. So there needs to be a period of time before it really becomes very useful and valid. Do you agree with that, Paolo? And Sarah?
Yes, I agree. This is a very hot topic at present, because there are different positions, in particular in the UK compared to other parts of Europe. But anyway, we have a review article that should appear soon about the use of C-peptide in clinical practice. Because at the end of the day, what we need to do is to have an assay that is reliable, helpful, but the problem is that is a value that may change according to even when you measure blood glucose at the same time. Because if you have blood glucose, just say you're 10 millimolar, and then you have a blood glucose of 5 millimolar, the C-peptide is influenced by that value. So if there is some residual beta cell function. So this is the reason why standardization of C-peptide measurement, according not so much to the assay, but to the clinical situation when you do the test, needs to be taken into account, even with the long-acting insulin. Because you may say, if you do the night before you take insulin, well, in the morning, you may have a suppressive effect of insulin on endogenous insulin secretion. So all these factors need to be calculated, and they are not calculated. So this is why C-peptide, at the end, did not come as the real factor that could help in defining treatment. And if you look at the ADA, ESD, or any other guideline, C-peptide is never mentioned. C-peptide doesn't exist. So I know that there are a lot of people involved in the standardization of C-peptide measurement, and we try our best with this article that should appear soon to clarify some of this issue. We really need, this is an unmet need, so we really need to find out what is the best parameter to use to select the right drug, because at the end of the day, what counts is that we have 9 different drugs available for treating diabetes. 9. I mean, this is a fantastic opportunity with 9 different drugs, but then we have to select which one is the best for that patient. And how do we select that? Well, it's not only evidence-based, but because we are missing some evidence-based data, but it's also our clinical perception of what the patient does, how the patient is compliant to therapy. Maybe they don't like insulin, the patient never likes insulin, and you cannot give insulin because they say, why do I need insulin if I take a tablet and my blood glucose is still normal? So I think there are so many variables that is really an unmet need, and we should work more and more on this form of diabetes that is still unsettled.
I think our time, the discussion is very interesting, and I don't think
Yes,
this
I
time
agree.
will give it its right, but it's really interesting. Precision medicine is growing to be a demanded part of medicine that we need to embrace in diabetes. Thank you very much for our eminent speakers. Very lovely session. Thank you very much.
Thank you, Adam. Thank you. Bye-bye.
Bye.